Laptop on.
Okay, ma'am, we are live now.
Okay. Just give a 2-line introduction, that's all.
Okay. So, good evening, all the faculties and delegates. On the behalf of Corona Remedies Private Limited, I welcome all of you for the this all about ectopic pregnancy live webinar. This is Searchlight 07 series, which is initiated by the Cancer Prevention and Relief Society in association with Ahmednagar, Ajmer, Akloj, Adur, Agartala, Ahmedabad, Aizawl, Aligarh, Option Gynae Society. So, first of all, it's my privilege to welcome our program director, Dr. Asha Jain. Dr. Asha Jain is a medical director of Cancer Prevention and Relief Society and director of SMSA Hospital, Raipur. And also, ma'am has also associated with so many these societies like CG Medical Council, IMA Chhattisgarh, and Foxy Food and Drug Medical Surgical Equipment, and also Mission Pink Health and ISCCP. And ma'am having so many academics, these certificates and awards also made good.
That's it. Let's proceed.
Okay, ma'am. So I welcome you and hand over this session to you and request you to please take it to the newer heights.
Thank you, Mehul. And now we start by invoking the blessings of the divine. So, requesting you to start with the blessings and then we do the formal program. Welcome, everyone.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय। ॐ शान्ति शान्ति शान्ति।
Ma'am, you are mute now. Ma'am, please unmute.
On behalf of Searchlight series, I welcome all of you. Namaskar. Today, our Searchlight is on ectopic pregnancy, and this time we have decided to take societies from east, west, north, south, a mix. It's not a comfortable, just a few people from one area. So let us see how the interaction will be. And I welcome Dr. P.C. Mahapatra, sir, who consented to be chief guest, Dr. M.C. Patel, sir, Dr. Ramani Devi, ma'am, who are my guests of honor, and convener, Dr. Sujay Shri. Also, I welcome our speakers, Dr. Meenu Agarwal, ma'am. She is going for vice president this year. Dr. Ganesh Bade, Dr. Sandhya Kumari, and Dr. Priya Vishwas Kadam as chairpersons for the first talk. Speaker, Dr. Pratik Tambe, sir, and Dr. Prasanna Kumari and Mukesh Savalia, sir, as chairpersons. And Dr. Rinpui from Azol as an expert, and Dr. Amit Karade, Dr. Revati Rane, Dr. Suchitra Narayan, Dr. Vanrem Mavai, Dr. Namrata Bharadwaj, Dr. Mukesh Patel, Dr. Ganesh Magbode, and Dr. Devadish Das as our panelists. I welcome all of you, and I hope this will be a really great learning experience. As our chief guest will be joining a little later, may I have the CVs of our guests of honor? Dr. M.C. Patel, sir. So, it is my privilege to introduce Sir. I've been working with him in his webinar series for quite a long time, and he's acted as a mentor to me. So, welcome, sir, to this series. He's a consultant obstetrician, gynecologist, and medical legal counselor, VP FOGSI 2018, organizing secretary AICOG 2017. He was the chairperson Ethics and Medical Legal Committee FOGSI 2011 to 13, and he continues to be a medical legal counselor to all FOGSians any time of the day or night for free. He also is associated with a National Medical Council group that actually works in the Northeast, providing health services for the last 21 years to the Northeast people. So I welcome you, sir, and seek your words of blessing.
Thank you, Asha.
Sir is also going for president election this year.
Thank you, Asha. Thank you for kind words. Sorry, my video is not working, but hopefully I am audible. So let me congratulate first for choosing very vital subject for discussion, ectopic pregnancy. Fertilized ovum implanted outside uterus, we know, as far as ectopic pregnancy is concerned. And if it is not diagnosed well in time and not managed well in time and very efficiently, then how it could be dangerous to the life of patient, we know. So as far as this topic is concerned, nearly 1 million cases per year in India is the statistic, and now with good sonography and some pathological laboratory test, it is easy to diagnose and to manage this condition well in time and very efficiently. If it is not managed well in time or not diagnosed in time, and if it ruptures, then it becomes a nightmare condition because it may lead to very torrential hemorrhage and ultimately patient may die. So very vital topic for discussion, and you have involved all the societies starting with A, Ahmednagar, Ajmer, Akluj, Adur, Agartala, Ahmedabad, Aizawl, and Aligarh. So let us see how all have to interact, northeast, southwest, and how interesting this CME becomes. So with this, I congratulate again and wish all the success to this webinar. Thank you very much.
Thanks a lot, sir. Thank you. Sir has joined in. PC Mahapatra, sir. Most welcome, sir. Most welcome. So, again, a really great honor and a great deal of happiness. Belated happy birthday, sir. You are happiness incarnate and you spread happiness wherever you are and all around. So, welcome, sir. Sir needs absolutely no introduction. He is an ex-professor and head department of obstetrics and gynae, SCB Medical College, Qatar. He's been the president of FOGSI in 2011, FOGSI representative to SAFOG 2014-15, VP FOGSI 2004, life member IMA. His life mission is born to serve, living for others and working till last breath. To be a man rather than a great man. Very much like what Swami Vivekananda has said, that, we be real men rather than trying to achieve something else. So welcome, sir. I'll be delighted to hear a few words of blessing from you.
Asha ji, sir is also the head of the BJP party in...
I know that, ma'am. I know. He will bring BJP to Odisha now with Ramchandra ji.
Thank you, Asa, and all the team members in this particular group, my favorite, all dedicated FOGSians, starting from MC Patel, Ramani Devi, Minu, and so on and so forth, and the young leaders who have really grooming the Foxy. And congratulations to this particular webinar organized by ASA. In fact, Dr. Asa has emotionally blackmailed me so that I'm here. So he has virtually dragged me from my OT and from my knife to this particular channel for that. I'm also very happy to be associated with this particular academic forum for that. And what is unique in this particular thing which I was marking, Asa, you have done an alphabetical societies in Foxy. I think this particular society beginning with A and your name beginning with A, I'm surprised to see this particular series with something special societies of Foxy and alphabetical society. Well, next is about the topic, the ectopic pregnancy. I think this is the topic of discussion today, and which is very common for the gynecologist, practicing gynecologist. Day in and day out, they must be seeing that lots of change has been there in terms of conceptual knowledge and in terms of the management protocol for that. And therefore, it is right that you have put the first session on TUL and non-tubal pregnancy as a different entity, which is important for the clinicians. And second important aspect about the medical management of ectopic pregnancy, and then the panel discussion and the case scenarios by the wonderful speakers and the wonderful Foxians will really elaborate and complete the scenario of ectopic pregnancy, right from the understanding to the etiology, to the diagnostic armamentarium, and the management protocol, which will be very helpful for the clinicians in day-to-day practice. I'm sure this particular type series of webinar organized by you will really give a new light to the Foxy academician and clinicians for that. Thank you very much for inviting me and as being associated with this particular wonderful and focused webinar, and particularly important for the day-to-day practicing gynecologists for that. Thank you very much.
Thank you, sir. Thank you. Thank you. I'm really honored to have you here.
Thank you.
So, may I have Ramani ma'am's CV? So, we have Dr. Ramani Devi ma'am, who is an MD, DGO, FICS, FICOG. We all know that she was the Foxy VP, and she has lots of prizes. She has PhD, and she is now taking over as Tamil Nadu Federation of Obstetrics and Gynecology President. This is a really, really huge CV. So she's got 10 gold medals. She's been a topper right
Asha,
from the
I
beginning.
think you
Yes,
can stop.
ma'am.
Now you can stop, but just introduce me as past VP of Foxy. And I think in front of sir, I'm nothing. In front of Dr. PC Mahapatra sir. Sir, good evening. Good evening, and NC Patel sir, good evening.
Good
And
evening.
Asha ji, it is a privilege for me that you have really honored me today for
Good evening,
having
madam.
me. Good evening, sir, for having me as a guest of honor for your today's program. As and it is very nice that you have started from A, and I hopefully you will complete the Z series of Foxy societies, all societies. And the topic today, I think, as sir previously, as MC Patel sir and Mahapatra sir said, that there are changing trends in both etiopathogenesis, diagnosis, and management. And previously, when we were postgraduates, 20% of the maternal deaths are due to ectopic pregnancy, and usually it will be a rupture ectopic. But we know that very rarely we have rupture ectopic. And previously, ectopic means it is only tubal. And very rare to see pregnancy of unknown location or ovarian pregnancy, cervical pregnancy, and added to this, the new entity of scar site ectopic pregnancy has increased. And most of, as we start doing our ultrasound very early, then we are able to pick up. When the beta HCG is around 1500, you must see a sac inside. Otherwise, we should keep a follow-up of that patient to rule out ectopic pregnancy. And again, the incidence of heterotrophic pregnancy, once it was, when we studied, it was 1 in 30,000, but I know now the incidence has increased, maybe following ART, and very rare combinations we get intrauterine with tubal, bilateral, tubal, intrauterine with ovarian pregnancy, scar site ectopic with ovarian, and so many things we get, so many combinations. And regarding the diagnosis, I think ultrasound high frequency machines are able to pick up ectopic pregnancy at a much earlier stage, and we do the beta HCG and doubling time and so on to diagnose it early. And regarding the ultrasound, usually all these patients with UPT positive, we are subjecting them to ultrasound by 6 weeks, which can help us to rule out ectopic pregnancy. Then regarding the management, once it was a surgical management, it is no more surgical. 80 to 90% of the patients, we are able to pick them up before it gets ruptured. So we have the many medical managements for ectopic pregnancy. And again, once it was only methotrexate, now we have so many newer medical management drugs, including letrozole and so on. So I think this topic is quite well chosen, and all the speakers and all the society participants are extremely good, and it will be really very good academic bonanza for all the participants of this particular webinar. And I also wish Dr. Asha Jain success for her future endeavors. Thanks for the opportunity, Dr. Asha Ji. And it is very nice to see Dr. Mahapatra sir. After, I think I didn't meet you in the AACOG, sir. Somehow I got missed.
I was sharing your session in endometriosis. How can you miss me?
No, sir, that...
I was sharing your session. I have heard your lecture.
Okay, sir. Okay.
I cannot miss Ramani Devi. You can miss me.
Asha, unmute.
Thank you, ma'am. Thanks for those kind words. And I'm really sorry if I've troubled all of you multiple times. I just wanted to make sure that you remember to be here. That's all. So thanks a lot for sparing your valuable time. Dr. Pratik Kamble sir has also joined in. Dr. Meenu ma'am is also here. So I think, sir, with due permission, we will start the academic program. So our topic, the first topic of the day is POL and non-tubal ectopic pregnancy. Our speaker is Dr. Meenu Agrawal ma'am, and we have 3 chairpersons, of which I can see just one right now, but I would like to introduce all of them in case they join in. May I have the slide, please? Dr. Ganesh Bade, KEM Mumbai Diploma in Endoscopic Surgery and President of Ahmednagar Obstetric Gynec Society. Welcome, sir. Dr. Sandhya Kumari is the President of Ajmer Obstetric Gynec Society. Welcome, Dr. Sandhya. And we have Dr. Priya Kadam, Director of Yashoda Hospital, Accident and Maternity Care, Akluj, since the last 11 years. She was the immediate past president of Akluj Obstetric Gynec Society and was before that the secretary, past president AOGS 22-23, chairman Women Wing IMA. She is also a lead assessor for Lakshya Manyata. Special interest in laparoscopy and infertility. Requesting you, Dr. Priya, please introduce Meenu ma'am.
Thank you, ma'am, for the kind introduction. I take this privilege to introduce Dr. Meenu Agrawal, ma'am. She is the president of Pune Obstetrics and Gynecological Society, National Director, Clinical Board, Ambilis IVF, elected board member, International Society of Gynecology and Gynecological Endoscopy, Chairperson, Imaging Science Committee, FOGSI.
Priya madam, thank you. This is enough actually.
Okay, ma'am.
So thank you very much, Priya Madam, for this kind introduction. Thank you, Asha ji, for inviting me over here. And very nice to be in the August company. I can see Dr. MC Patel sir, Dr. Ramani Devi Madam, Dr. PC sir. So very, very glad to be here. In the how do I screen share? It is showing host disabled attendee screen sharing. So they
Just
will.
a second.
Just
Sure.
Mehul, please
Yes,
enable madam.
yes, ma'am. Now you can do.
Ma'am, you'll be able to share.
Okay, all right. Okay. Can you see my screen?
Ma'am, minimize the video.
Yes, ma'am, we can
Yeah.
see it, but if you can, yeah, enlarge your screen, it'll be better, ma'am.
Okay. Oh my God. Something is not right. Sure.
Ma'am, stop sharing first.
Okay. All right. Hmm. Can you see my screen?
Yes.
Yes, ma'am.
But
Yes, ma'am, we can see your screen, ma'am.
Okay, fine.
no, ma'am, we are.
Ma'am, make it full screen. Yes.
Yes.
Hmm.
All right. So
But
thank
this
you
is-
very.
Hello?
Sorry. Yes.
Ma'am, this is your entire. This is Zoom screen only. So I think first.
Okay, you cannot see my screen.
Ma'am, we
Yeah,
can
but-
see your slides, ma'am. We can see your slides.
So shall I go ahead?
Yeah. Mr. Mehul, is it okay? Can ma'am proceed?
Yeah.
Okay. So I shall be talking about extra-tubal pregnancies and pregnancy of unknown location. This topic given to me. So as PC sir said, when we talk about ectopic pregnancy, that means the fertilized egg is implanted outside the normal uterine cavity. Why does it implant outside the normal uterine cavity? Various reasons. It can be some kind of inflammation, smoking. ART pregnancies do tend to have higher risk of ectopic pregnancy. And how do we diagnose it? Mostly by ultrasound and also by serial beta HCG levels. Now, when we talk about ectopic pregnancy, 1 to 2% of all pregnancies can be ectopic. Out of this 1 to 2%, 98% are tubal ectopics. So what I'm going to talk about is rest of the 1 or 2 0.1 or 0.2% which are non-tubal or which are pregnancy of unknown location. So I will go case wise, so it will be more interesting to see the videos and the cases. This lady, she is 29 years old. She came with amenorrhea of 11 weeks. Para 1, she has a 3-year-old child. Previous cycles are regular and pregnancy test done at home was positive. We did an ultrasound, so we can see this is the normal uterine cavity over here, and we can see something over here which looks like a sac. Again, did a 3D ultrasound, so we can see this is a uterine cavity which is normal, and this is like a pregnancy sac which is seen in the another horn of the second horn of the biconvate uterus. So this is the accessory horn. So this is where it is situated. This is where the pregnancy is situated. And what is the plan of the surgery? The plan is that we need to resect it from here, and we need to resect it from here, and we also need to resect this fallopian tube because it will have no meaning if we leave it behind. So this was the plan for the case. It was already an 11 weeks pregnancy, so medical management was not a good option. So we discussed it with the patient. So what we have done is we have kind of a standardized a technique managing these extra tubal ectopic pregnancies. So we use injection vasopressin. we first, you can see here, we first disconnected both. It is like a mini hysterectomy. So we disconnected both the round ligament and the fallopian tube on the affected side, following which we injected pitocin. Okay, so what is the dose of this vasopressin that we use? So 0.05 is the dilution that we use, and it is injected just at the junction of the ectopic pregnancy or this horn to the normal uterine cavity. After we have injected this, the main concern is that we should not have bleeding. So that is the main concern here. So what we do is we take a purse string suture all around. So you can see here, we first use an endo loop there, following which we just went around with good assistance. You can see my assistant, Dr. Madhuri Kashyap, is standing on the right side. I am standing on the left side, and we took another purse string suture all around it. After we have taken two sutures, then you can even use a bipolar. What we have used here is we have used a harmonic scalpel here. So with harmonic scalpel, we go just at the distal end of the loop and then go all around and then resect this. And you can see here, there is not even a drop of the bleeding. So we went all around, and I'm just slightly fast forwarding because this is the basic understanding that what has to be done. So just go all around above the loop. If we take only one endo loop, sometimes it tend to slip because it is not, there is no suture. So we take one endo loop followed by suture into the tissue so that it does not slip. So once we have resected the whole thing, you can see there is not even a drop of bleeding. We go ahead, we resect the whole thing with the help of a harmonic. We can also use bipolar and scissors if we don't have harmonic, but harmonic is very, very useful over here because it cuts and coagulates, and we don't need to change hands and we don't need to change instruments. So as you can see here, this whole thing is separated now, and what I was just wanted to see whether it is connected. So I incised it inside the uterine cavity. You can see the pregnancy sac coming out, and then we cut it open, and it was blind. So just to prove that there is a transmigration of the sperm coming from the one fallopian tube towards the other fallopian tube. So this is how, so any pregnancy which is outside the fallopian tube and little at a tricky place, that can be managed. And you see there is absolutely no connection. It was a rudimentary non-connecting horn of the bicornuate tube. So this was confirmed, and then we took it out and sent it for a histopathological examination. So second case, she is a 25-year-old lady. She came with 9 weeks amenorrhea, again already have one child. She had taken medical termination of pregnancy with a local doctor. No bleeding, so she was referred to us. When we did the ultrasound, this is what the report is. So whenever we are looking at an ultrasound, always make the bladder as your reference point. This is the white line between the bladder and the uterus, and we can see it is sitting over here. This is the level of internal loss or the ilex or the uterine vessels. So this is a pregnancy scar ectopic. Nowadays, not very uncommon to find scar ectopics, but this was first, initial, this about 4 or 5 years old video. So that time we were not, this was my first case of scar ectopic that I had operated. And so we were little anxious also that how we are going to manage. So, but we went as per whatever is mentioned in the books. So we first open the bladder peritoneum, push the bladder nicely down, and till where we have to push the bladder is when we see a bluish color. See, once we see, I'll just fast forward it. It was done in a single chip camera or simple normal camera there. So you can see that the bladder is pushed nicely down, and once the bladder is pushed down very nicely, you can see this thinned out area, and this area is the site of the scar ectopic where it is implanted. And once you see this scar ectopic site, then we again have here used harmonic. So you take the active blade of harmonic and just puncture it at that site, and make sure that the bladder is pushed down well. That is the most important part. And once we have opened this site of ectopic pregnancy, you can see this all this amniotic fluid coming out, and then we remove the sac, and then we go ahead for the nice suturing. So that time we used to suture, as I said, very old video. I used to use Vicryl at that time. Now we are using mostly Vlog for these cases. So that is an important thing that we can use. So whenever we talk about scar ectopic, very important to understand the presence of isthmocele on ultrasound. So whenever, how many of you all are doing ultrasounds yourself, always look for isthmocele even if the patient has no symptoms. So when the patient comes with symptoms of any post-menstrual spotting, bleeding, infertility, foul smelling discharge, then and previous history of C-section, then we on ultrasound we can diagnose, and we can either treat it hysteroscopically or we can treat it laparoscopically. So this is how it is again done. This is the non-pregnant state. This is how it is laparoscopically management of isthmocele, that you push the bladder again very nicely down and remove all the scar tissue, that is very important, and put a dilator in the cervix so that you know the lower uterine edge, and then you suture it with the help of a Vlog suture. Very very simple surgery to do. So but just see one case nicely done, and you can do it yourself. This was another case. She's a 29-year-old lady, male factor infertility, history of lap myomectomy done for a 6 centimeters intramural fibroid, uh, ICSI-ET done after 6 months of myomectomy. She came to us with a missed abortion at 9 weeks. First, a medical management was given. She didn't bleed. Then we planned for a DNA. I did a DNA for her, and we found there were no products of conception. So in our OT, we always have the ultrasound machine. So immediately we did the ultrasound, and we could see the sac. We got a bit worried. I said, "Why is it happening? We can see the sac, and we are not finding anything." I immediately put a hysteroscope. And when I did put a hysteroscope, I found that the uterine cavity was empty, but there was a sac seen on ultrasound. And then it clicked that maybe it is a myomectomy scar ectopic. So this is how the pregnancy was. You can see here, this is uterine cavity which is empty, and this is a pregnancy sitting all surrounded by the myometrium. So then we knew that how to diagnose an ectopic in the myomectomy scar. This patient's relative was a doctor. We've searched the whole literature. We didn't find any case of laparoscopic management of such a case. Patient's relative was a doctor, and we explained to him. So he said, "Okay, you can go ahead laparoscopically, and keeping in mind that SOS, if required, we will go for an open surgery." So again, we went through the same principle. We injected local diluted vasopressin at the junction of the ectopic and the healthy uterus, and then we went all around, and we took a suture to take a purse string suture all around. Rizwana, I'll call you back. So, and nicely tightened it. Again, main concern was that she should not bleed. Once we took a purse string suture all around and with vasopressin, then you can see here we used harmonic, and then we resected the this whole pregnancy thing. So you can see here, you can see the membranes bulging out over here, and no bleeding. The main thing is that we are operating on a pregnant uterus. We are always scared of the bleeding, and this using of vasopressin and purse string suture, it just helps that the bleeding is much less. And then we took out the whole pregnancy, you can see over here, and then we sutured it nicely, and this patient conceived in subsequently we actually transferred a single blast for her, but she conceived with a twin pregnancy, and she carried the pregnancy till 38 weeks. We wanted to do a section at 36, but they had some muhurat ka din, and we admitted her, and we kept on postponing. Finally we did a section at full term C section. We published our case here. You can see in 2017 we published this case, and this was our first case of laparoscopic surgery. Myself and Dr. Madhuri Kashyap and my assistant Dr. Sandhya Mishram. So all of us published this case. So what we should do to avoid such a kind of an ectopic pregnancy? Whenever we are doing a myomectomy, you see here. So whenever you are doing a submucous fibroid, big in size, you are doing it laparoscopically. So push some methylene blue. If you have even slight mm, doubt that you might have uh, opened the cavity, does not matter even if we open the cavity, no problem. Only thing is we have to go very close to the fibroid, push all the endometrium whatever is seen inside, and when we are taking sutures, don't take this endometrium in the suture. So tell your assistant to push this endometrium in with the help of a grasper while you are suturing the myometrium. So these are some precautions that we have to take for this particular, to avoid this. Then again, this lady, she came, she was amenorrhea 6 weeks, pain in the left iliac fossa. Now, these all could have become a pregnancy of unknown location, because they are not in the tube, but they could be diagnosed. So her UPT was positive. She had a history of ruptured ectopic, and salpingectomy was done on the left side. Para 1, ectopic 1. Now, we did an ultrasound for her, and this is not a very clear ultrasound, but you see here, empty uterine cavity. There was one intramural fibroid, and ectopic pregnancy sac was seen on the left side. So you see here, she has had a history of salpingectomy done on the left side, and now ultrasound is showing ectopic pregnancy on the left side. I mean, obviously, the patient is also wondering, and so are we. How can there be an ectopic seen on the left side when she's already had a left salpingectomy done? So we did a laparoscopy for her, and lo and behold, you can see this is the pregnancy at the ipsilateral tubal stump. So total salpingectomy was done. It was not partial salpingectomy, and yet the ectopic pregnancy happened in the stump. So I remembered Professor Kurt Sem's words that you should cut the end of the tube in a saucer shaped manner. The pregnancy can still happen in the interstitial part of the tube or in the stump of the tube. So we must at least coagulate the stump nicely whenever we are doing a total salpingectomy. This is another lady, 33-year-old. She came with acute pain, abdomen, shoulder pain, giddiness, only 5 weeks amenorrhea, some PV bleeding. UPT was negative. Okay, beta HCG 195, but there was fluid in the pouch, both the foci and infrahepatic area. So this was again a good case, corneal ectopic. Now, corneal ectopic is how to manage. Again, we are worried about the bleeding. So first, separate the entire tube. You can see here. So we just dissected with the help of you can use a harmonic, and then go at the base here. Go at the base here, and then just tie the loop nicely, so that will prevent the bleeding. It can actually bleed very torrentially if you directly go there. So just use this nice purse string here, and then when we separate, when we do a salpingectomy, at that point of time the bleeding is much 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 less. In fact, it is not there at all. There are cases where in a corneal pregnancy or a true interstitial pregnancy, that means it is in the interstitial part of the tube, there are case reports where they have opened it, removed the pregnancy and closed it, leaving the fallopian tube behind. So they have saved the fallopian tube, and this is something, the new graduates can do it. I mean, but it is just in some publications that some series have, they have reported these cases. So And these are the few cases that I wanted to discuss with you. And of course, sometimes we do get the pregnancy test is positive, beta HCG say is showing 1500, 2000. We do the ultrasound and we don't find it. Why we are not finding a tubal ectopic? Because we are only looking at the fallopian tube. So we have to look at other sites also. We have to look at if she's had a history of myomectomy done, or other places. You can sometimes an abdominal pregnancy also is there. What is the management? Only and only by serial beta HCG. So repeat beta HCG after 48 hours. If the beta HCG is going up, you will find an ectopic or an intrauterine pregnancy sometimes, which is seen much later, and then you can pick it up. So pregnancy of unknown location can really put all of us in dilemma, especially in patients who have undergone ART. So beta HCG is positive and we say we can't see the pregnancy. Even cervical pregnancy, sometimes ectopics take a long time to show up. Sometimes we are not looking at the scar area. So all these areas we need to look at whenever we are dealing with pregnancy of unknown location. Most importantly, we have to keep doing HCG every 48 hours, counsel the patient, and as and when required, tell them that ASAP they can report to the hospital if they have any pain. Even shoulder pain, very important sign of a ruptured ectopic is shoulder pain, and then this patient should be counseled in a nice way. So thank you very much. Thank you, Asha ji, for giving me this opportunity, and if there are any questions I can take them. Thank you so much.
Thank you so much, Dr. Meenu. Please stop sharing.
Yes, I'm doing that. I don't know something.
Dr. Priya, would you please take over? That was a real visual treat that you gave all of us.
Yes, ma'am. Thank you, Meenu ma'am.
Over to you, Dr. Priya.
Yes, ma'am. Thank you, Meenu ma'am. It was a real eye-opener. Very rare cases were very nicely explained with a video presentation, like Cornwall pregnancies, then Horn pregnancy. The take-home messages are that we should start doing ultrasounds and start diagnosing the scar ectopic and hysteroscopies. And also the take-home message of doing the serial beta HCG in the cases where we are confused about the whether it is a ectopic pregnancy, for example, in the cervical pregnancies. I would like to ask ma'am how to treat the cervical ectopics.
Yeah, cervical ectopic, there are various ways. One, of course, we can do a medical management. That is one possibility. Second is when we use a transvaginal probe and we can inject either methotrexate or KCl into the sac. So that is the second way to do it. So these are the two things, and then do serial beta HCG levels, and if they are falling down, but cervical pregnancies do tend to rupture. So we have to counsel the patient when we are giving them the medical management for these
Yes.
patients. And of course, hysteroscopically also they can be managed. It is possible to manage them hysteroscopically as well. Yes.
And one more thing, it is said as it advances, cervical pregnancy mostly they get aborted.
Yes, they do get aborted. Yes, but they can also
bleeding. So if it is bleeding, then only we can go for surgical management.
We can first go for medical management, and if we should not wait for it to just abort by itself, we have to do something. We see a live ectopic in the cervix, so you go for the medical management. Medical management not working, in that case we can go for the injectable transvaginally, and third option is a surgical hysteroscopically.
Okay, ma'am. Thank you, ma'am. Very nice lecture.
Thank you.
Thank you, Meenu ma'am.
Thank you.
It was really a visual treat. Thanks for being with us today and making this webinar interesting. And now we have the second part, and we have Dr. Prateek Tambe sir with us. So we have Dr. Prasanna Kumari ma'am, who's the president of Adur Society, and Dr. Savalia is in a managing committee meeting and might not be able to join. May I have the CVs, please? So Prasanna Kumari ma'am is the head of the department and senior consultant, obstetrics and gynecology, Lifeline Hospital, Adur. Senior consultant and gynecologist at SUT Hospital, Trivandrum. Former professor at Government Medical College, Calicut and Trivandrum. She is the author of Postgraduate Gynecology. She is awarded WHO Fellowship 1991 and former president of KFOG. Welcome, Prasanna ma'am.
Thank you.
Next, please. We have Dr. Savalia sir with her, Mukesh Savalia, who's the president of Ahmedabad Obstetric Gynec Society. I request Prasanna ma'am to take over and introduce our eminent speaker, Dr. Pratik Tambe sir. Prasanna ma'am.
Dr. Pratik Tambe, MD FICOG, ART consultant and gynec endoscopic surgeon of Ashirwad IVF Mumbai, an international diploma in advanced laparoscopy surgery of France, and is trained in assisted reproduction in Belgium, trained in clinical embryology ICSI at London and Singapore. He is the chairperson of AMOX Endocrinology Committee, governing council member, Indian College of Obstetricians and Gynecologists, so many accolades. Managing committee member, Indian Society for Assisted Reproduction, the recipient of 30 MOX, ISAR, and FOXY prizes and awards, the editor of 24 books, 4 FOXY focuses, and handbooks. Very hardworking. 11 key practice points. Contributed 100 chapters, invited faculty of 1,000 events organized, and is the convener of ICOG Reproductive Medicine course. Peer reviewer of Journal of OB-GYN of India, JOGI. So let me introduce Dr. Pratik Tambe for his talk on medical management of ectopic.
Mr. Mehul,
Over
sir
to
is
you,
requesting you
Pratik,
to
sir.
make him a co-host. Mr. Mehul, sir is requesting you to make him a co-host to share his slides.
Yes, ma'am. Yes.
Thank you very much, Dr. Asha Jain, ma'am, for inviting me to this prestigious event. It's always a pleasure and a privilege to be with Dr. Asha Jain. We have worked together since several years. I remember visiting Raipur several times when I was FOXY committee chair for the endocrinology committee. She is a fantastic host, an amazing personality, and she has worked very hard in Chhattisgarh, Raipur, and the surrounding areas to increase the level of healthcare that is delivered, as well as the commitment that she has shown. Many people have been inspired by all her work. She is actually on the medical council as well, if I'm not mistaken. So I'm here today to speak about the medical management principles in ectopic pregnancy, which is a very boring talk. I will try and make it a little bit interesting because very honestly, not much has changed since 30 years when I was a medical student and I was a postgraduate. But let's see what new emerging areas we have in this particular field. As you are aware, I'm fond of quotations. Today's quotation comes from Aristotle, and he said once upon a time, nearly 2000 years back, that choice, not chance, determines your destiny. And by this particular quotation, I want to draw your attention to the fact that we as clinicians hold patients' lives in our hands. It is very important for us to make the right choices at the right time to ensure that we can intervene in the appropriate fashion to take care of our women. Whenever I speak about a topic, I like to start by asking whether whatever I'm speaking is actually clinically relevant, or it's just some topic which is there as part of a conference or a webinar, and it doesn't actually have much clinical relevance. So to speak of ectopic pregnancy, all of us are aware that it is one of the most important causes of maternal collapse, obstetric shock, and emergency presentations to the accident and emergency, or A&E as it is, because it results in implantation outside the uterine cavity. The most common of these is the tubal ectopic, which I'm going to speak about. What is not much known by our fraternity is that it is even today in 2024 a leading cause of maternal mortality. In fact, 5 to 10% of all maternal mortality even today is as a consequence of ruptured ectopic pregnancies, which are undiagnosed, which may be missed, or maybe the patient has not presented at all in the first trimester for confirmation of pregnancy. If you look at the classic presentation of lower abdominal pain plus a vaginal bleed, which is probably one of the most common presentations in the first trimester, both to OPD as well as emergency, about 18% plus are actually ectopic pregnancies in disguise. I remember 30 years back as a resident, we would often just give them something called as gyne-CVP and tell them it's normal, it's okay. Go and get an ultrasound done in the radiology department. The poor woman would queue up for hours together. If she was lucky, she got a scan done on the same day. If she was unlucky, she would have got an appointment 2 or 3 days later, which might be too late if she already had an ectopic and she would come back with a rupture in the middle of the night. Fortunately, healthcare in India has improved since 3 decades, and I'm pretty sure that this is a rare occurrence. It doesn't happen very commonly anymore, but that just shows you how, in what cavalier a manner we actually take women who present with first trimester bleed. So how often does this rupture actually occur? About 15% of all ectopic pregnancies rupture. And this is more relevant in today's age because the incidence of heterotopic pregnancies has increased significantly. In fact, the normal background risk of having a heterotopic or double pregnancy, both intrauterine as well as a tubal ectopic, is about 1 in 7,000. After the advent of ART and widespread use of IVF, this has increased to 1 in 100, which is a huge change. And you see what happens when a patient conceives with IVF. Everybody is very happy and they're celebrating because she got 2 positive, 2 red lines on that UPT, and her beta HCG was more than 100. When you did the scan at 6 weeks, you saw an intrauterine pregnancy, you were very happy, and that was the end of everything. You never actually bothered to look at the adnexy, you never bothered to look at the ovaries. And that is where heterotopic pregnancy is missed. I think this has already been covered by the preceding speaker. You know that there is a huge increase in number of cesarean sections, which has been happening over the past 2 or 3 decades. And because of the lazy practice of, I only call it lazy because I'm an old timer, I still close the uterus in 2 layers. The modern practice of closing the uterus in 1 layer sometimes leads to a thin scar, and that leads to a scar ectopic or a cesarean scar ectopic, which is known, it's a known entity, and you've already seen in the preceding speakers' videos that this is not something which is rare, it presents quite commonly these days. To be very honest, I have never seen a cesarean scar ectopic in my residency days 30 years ago. That's probably because we closed the uterus in 2 layers, there was no laziness there, and probably the interpregnancy interval was also significant in these women. Having said all that, we remember that we have been taught since decades that ultrasound and serum beta HCG serial monitoring form the mainstay of both diagnosis as well as therapy. What is the current evidence as it stands regarding ectopic pregnancy? There's an ACOG practice bulletin which was issued in March 2018 by the American College, and the clinical practice bulletin highlights various different important issues. And if you want to look it up, then this is the original publication in the Green Journal Obstet Gynecol. That's the reference at the bottom in case you want to look it up. It's a little old, probably it should be updated, and it was due for updating during the COVID pandemic, like a lot of other guidelines, in which unfortunately have not been updated because of various issues related to the pandemic. There's also the RCOG guideline on diagnosis and management of ectopic pregnancy. This is the Green Top guideline number 21. Again, this is quite old, published in November of 2016. This is much overdue for an update, and hopefully they will do that in the near future. Again, that's the reference at the bottom in case you wish to look it up. But most importantly for today's talk, we have a more recent paper. This is published in Women's Health in 2023, in fact, and this looks at about 10 to 12 years of publications on ectopic pregnancy, and it has summarized everything very beautifully. That's the reference there. in case you want to download that paper. If you can't find any of these papers or guidelines, feel free to write to me. I'll be happy to email you a copy as soon as possible. So how has ultrasound revolutionized our diagnostic approach? We know that ultrasound characteristics are of paramount importance. The days when we used to see a simple intrauterine sac on ultrasound and be happy that the patient is pregnant are now over. We need to have a high index of suspicion, and wherever you have what is called PUL, or pregnancy of unknown location, you need to look at all these different signs like the interstitial line sign, the bulging sign, the sliding sign, the ring of fire on color Doppler, the blob or bagel sign. All of these have been described. And of course, it's beyond the scope of today's discussion to talk about all of these. And these are very specific for different locations of an ectopic pregnancy. The most common, of course, is the tubal ectopic, which you can see from this table is about 95%. But the others are not very far behind. And with the advent of higher cesarean section rates, as well as ART, we know that these other types of ectopic pregnancies are also going to become more frequently encountered as time goes by. What is the difference between serial beta HCG monitoring as we did it 2 decades ago and today? Honestly, not much has changed. With an HCG level of more than 2000, and if you don't see an intrauterine pregnancy, this is very highly suspicious of an ectopic pregnancy. Intrauterine pregnancies that are viable are 99% likely to have at least a 49% increase in the serial levels when you give a gap of 48 hours between 2 successive readings, especially if the initial levels are less than 1500. We'll come to that in just 1 minute because the next slide gives you those details. We know that if the HCG levels don't rise as per the expected, that is more likely to point towards either an ectopic or a miscarriage. And a decrease in the level is most likely a diagnostic sign of a failed intrauterine. What are the cutoffs in clinical practice? This is what I was referring to. When you have 2 levels at least 48 hours apart, the rate of rise or increase is expected to be 49% if the initial level, the first level, is less than 1500. If it's between 1500 to 3000, then the rate of rise is about 40% expected. And if it's more than 3000 in the first instance, then it is about 33%, which means that if your rate of rise is less than these levels, then that's more likely to point to an ectopic pregnancy or a tubal pregnancy. Are there any other more recent markers that we have besides the ubiquitous serial beta HCG? Yes, you have something called as activin AB, there's something called as ADAM12, there's microRNA, there's PAPA, and there is progesterone as well. And all of these with varying degrees of success have been used in various different studies. These are small studies with 100, 200 odd patients. There's not enough data to come to a conclusion. And very honestly, there is no marker which today has either replaced the serial beta HCG estimations, which we've been doing since donkey's ages, or we've been able to combine it with the serial beta HCG to give us a better composite marker. Like for instance, your first trimester screening, which we do to rule out chromosomal anomalies, we don't have something similar for ectopic pregnancy even today. Maybe this will change in future, but we don't know as well. What are the basic medical management principles? Now, this depends a lot on where your pregnancy is and what is the hemodynamic state of the patient. Today, we are lucky that we have good facilities for ultrasound and accident and emergency in most cities and small towns, even tier 2 cities, as well as small towns and villages in India. There are very few clinical scenarios where the patient presents with a ruptured ectopic or is denied treatment anymore, because India is much different today as compared to 2 or 3 decades ago. For the tubal pregnancy, obviously medical management with methotrexate is indicated in patients who have an unruptured ectopic pregnancy, but the patient has to be hemodynamically stable. And ideally, what we were taught in the good old days is make sure the patient is admitted and is under observation so that she is not lost to follow. Surgical management is recommended for patients who are hemodynamically unstable or they don't fit into the criteria for medical management. What are those criteria? We'll come to that in just one or two slides. As far as interstitial pregnancy or corneal pregnancy is concerned, most of the time these patients bleed and they require surgical management. Medical management is not very much favored in these cases, though on this table it says that it may be considered for hemodynamic. Cesarean scar pregnancy, I think Dr. Meenu answered one of the questions. Intragestational direct administration under ultrasound of methotrexate is the treatment of choice. It's the gold standard as far as medical management is concerned, and that is superior to systemic or intramuscular administration of methotrexate, which we do left, right, and center for tubal ectopic pregnancies. Also, laparoscopic approaches are something which can be considered in these patients. As far as cervical pregnancy is concerned, heterotopic pregnancy is concerned, most of these cases require surgical management, because in heterotopic pregnancy, there's already an intrauterine pregnancy. You can't give methotrexate because you will kill the intrauterine fetus. And cervical pregnancies usually don't respond so well to methotrexate unless you are combining it with something else. What is that something else? We'll come to towards the end of this talk. Ovarian and abdominal pregnancies obviously require a surgical approach. So is methotrexate still the gold standard even today after 25-30 years since it's been described in our textbooks? Yes, unfortunately or fortunately, whichever way you look at it, it is still the gold standard. It's a folate antagonist, so it works against rapidly dividing cells, which also means that once you diagnose an ectopic pregnancy and you're giving methotrexate to the patient, please stop the folic acid because it will counteract the effect of methotrexate. I know it sounds very stupid to say so, but this is a basic mistake which many of us make. The various contraindications which are described to methotrexate therapy are if the patient is hemodynamically unstable, she's in a state of shock, or she's leaking quietly, she's had a tubal abortion, and you find that her hemoglobin is, PCV is decreasing over time. That's anemia, leukopenia, thrombocytopenia. All these signs when you see, obviously you're not going to administer methotrexate to that patient. If she has a past history of renal or hepatic insufficiency, pulmonary disease, peptic ulcer disease, you know that this patient is not a good candidate. And specifically from the pregnancy OBGYN point of view, if she has an intrauterine pregnancy, she's breastfeeding, if there is cardiac activity that is seen on ultrasound and HCG initial levels are more than 5,000 or a sac more than 4 centimeters, you are not going to administer methotrexate to this patient because it's not going to work. So if you have a confirmed ectopic, she's hemodynamically stable, unstable, an unruptured mass, cardiac activity is absent, then these are the patients who are prime and good candidates, especially if the HCG level initially is less than 1,000. Who should you not offer methotrexate, especially if your HCG levels are more than 5,000? The failure rates are as high as 14%. With a beta HCG level of less than 5,000, your failure rates are as low as 3%. Is a single dose of methotrexate adequate? Now, by single dose, we must remember that the dose recommended in textbooks is 1 milligram per kilogram body. Now, in the good old days, women were lightweight, 50-60 kilos, so single dose of 50 milligram, that's the single vial of 50 milligram was adequate. Today, we must remember that women are considerably heavier, they may be 60, 70, 80 kilos. So administering that single vial or single bulb of 50 milligram is inadequate. You must weigh the patient and make sure you give 1 milligram per kilogram body. This is one of the prime reasons for failure of single dose therapy of methotrexate. The second reason is the patient is continuing to take the folic acid, which works against methotrexate. We just covered that. Multiple dose regimens are more effective. You can see that the success rates are more than 92% versus 88%, but the single dose regimen has lesser adverse effects. If you find that the fall of HCG from day 4 to day 7 is less than 15%, then you are going to have a greater risk of failure of therapy and therefore a second dose may be required or she may require surgical intervention. We'll come to that in just 1 or 2 slides. Is there a simple protocol that you and I can follow in clinical practice? Yes. If you look at the single dose regimen, on day 1, you send the blood parameters, CBC, LFT, RFT. You give your single shot of 1 milligram per kilogram body weight IM. On the 4th day, you measure your serum beta HCG. On the 7th day, again, you measure the serum beta HCG. On the 4th day, the level may not decrease or it may even increase by a small amount. That is absolutely normal. Do not be alarmed. Wait till the 7th day. On the 7th day, if your HCG decreases less than 15%, then your methotrexate has not worked. Then you should give your second shot, or you should consider surgery. This is the simple single dose regimen. There are 2-dose and multi-dose regimens also, and they are laid out very nicely in this table. For reasons of paucity of time, I'm not going to cover that. I'm going to move ahead. So how effective is methotrexate? Ultimately, you see success rates of nearly 95%, and this depends on the lower initial serum beta HCG level. If you have a level of less than 1,500 or 2,000 when you administer your methotrexate, your chances of success are going to be significantly higher. In textbooks, there is a description of an immunomodulator drug called getifinib. I have no personal experience with this, but it's been described in textbooks that if you give it orally for 7 days along with MTX, it eliminates the need for a second dose, and these patients are not going to require surgical management. 100% cure rates with methotrexate alone in combination with this drug called as getifinib. Besides your serial serum beta HCG measurements, there are other parameters which have been described for monitoring, but of course HCG is something which has stood the test of time. These other parameters like neutrophil to lymphocyte ratio, CPK, all these are something which are described in research but not commonly used in clinical practice. The last part of my talk is to talk a little bit about recent advances and specifically the focus on fertility preservation. Uterine artery embolization has emerged in a big way over the past couple of decades for preserving fertility and as an adjunct to methotrexate. And as we just saw, if you have a cesarean scar ectopic or you have a cervical pregnancy, uterine artery embolization along with methotrexate is supposed to be giving you greater than 90% cure rates. In fact, local infusion of methotrexate and 5-FU, 5-fluorouracil, is something which gives near 100% cure rates even in patients who have cesarean scar ectopics and cervical ectopics. This is something which needs to be borne in mind. High intensity focused ultrasound followed by DNC is also something which has been described. It's not something which I have personal experience with, but since it's mentioned in the books as one of the alternatives and one of the emerging therapies, I thought I should just make a mention in passing. And in women who have persistent bleeding and who have persistent high levels of HCG after the first dose of methotrexate, uterine artery embolization has been shown to be safe, effective, and gives good cure rates, prevents surgery or avoids surgery in these women. So what are the implications now? This is the last question. This is something which is very interesting because a lot of things have changed in the past 6 months. You'll be aware that in America now abortion is banned. They don't have an abortion act. They had an archaic judgment sometime in the 20th century called Roe versus Wade, where the Supreme Court decided that a woman should be given the choice of aborting or terminating her pregnancy. Recently, 6 months ago, that has been overturned or reversed, and therefore abortion is no longer legal now in America, in most states in America, to be very specific. Now, this gives us very interesting scenarios, a lot of challenges in treatment. Of course, I spoke about this when I was talking to Dr. Jaideep Tank in one of my AMA sessions. We know that mifepristone and misoprostol is now no longer available widely, and it cannot be used in patients who have pregnancy of unknown location. We know that when you give M plus M and methotrexate, it results in very rapid expulsion of ectopic pregnancies. But the problem is that when you don't have these drugs widely available, when even an ectopic pregnancy is considered a life and it has rights of its own and it is allowed to continue, we don't know where this situation will end. The AMA, the American Medical Association, and the American College of OBGYN consider all healthcare, abortion, contraception as a basic human right, but then the government and the Supreme Court of the US doesn't follow that particular point. Unfortunately, the rest of the world tends to ape what America does. So I'm not sure how long we will be prescribing methotrexate and how long medical management will be allowed. Maybe it will be uterine artery embolization and other drugs that will come to the fore over the next few decades. So a few key practice points to round off today's presentation. We know that ectopic pregnancy, specifically ruptured ectopic pregnancy or tubal pregnancy, is the most common cause of first-trimester maternal mortality even today. Early diagnosis using ultrasound and serial beta HCG estimation is essential. Good counseling, talking to the patient, admitting her, making sure she's under observation, and offering her medical management early on before the HCG levels are high is of paramount importance, because that is what yields the best success rates. Methotrexate still remains the gold standard today. There are other agents which have been used in combination. A second dose may be required, especially if your HCG level does not fall greater than 15% after 7 days. Close observation, follow-up, and taking the right decision for surgical exploration at the right time is of paramount importance if you want to save a woman's life. So, ladies and gentlemen, excellence is never an accident. Make sure you are offering the right choices at the right time to your patients. Sincere effort and intelligent execution. Thank you very much for a patient hearing. Thank you, Dr. Asha Jain, for inviting me to speak to this office.
Thank you, sir. That was, I just read that paper and I've made my panel on that paper. So you've made it easier for everyone. So that was really great. And even I learned something new. Ramani Devi ma'am is there. Ma'am, would you like to say something before Prasanna ma'am?
Pratik, have you tried letrozole for medical
No,
management?
personally, I've never tried.
It's
Never
really,
tried.
it's really good. I have tried for few of my patients, and especially for patients with a very high level of see, like that some I think the question of having a fetal heart using methotrexate is only, it's not always the fact, because there are anecdotal incidents where even if the effect is there, we can use methotrexate, but provided the patient is under constant surveillance.
Absolutely.
See, that is one important thing. It's not that we cannot, the ectopic.
It's not an absolute contraindication. You're right, ma'am.
Yeah.
Ma'am, what is the dose of letrozole you're using?
I'm going to come to that. It is 2.5 milligram TDS. I use it for 5 to 7 days.
Okay.
Mino, have you tried?
No, I have not tried letrozole.
Okay, but
Prasanna ma'am, Prasanna ma'am, would you like to add something?
I wanted to add a few points. I have not tried letrozole, but I have tried mifepristone.
Mifepristone is also good.
The success rate will be high. What I have to say is, widespread use of ultrasound and beta HCG. I think more ectopic pregnancies are unnecessarily being managed laparoscopically or giving methotrexate. Some of them will fail as intrauterine pregnancy. See, as you have already said, no, we can repeat the beta HCG and transvaginal ultrasound every 48 hours. Make sure it is growing, and then only we would like to interfere. And especially because of the widespread IVF procedures, there can be heterotopic pregnancies. So when you see an ectopic pregnancy, don't jump into methotrexate or medical management or surgical management, because a much wanted intrauterine pregnancy may be there. And another thing is, if the pregnancy is multiple, even if it is 2,000 or 3,000, we may not see the sac. It is because of the added effect of the multiple gestational sac. The beta HCG is so much high. So in that case, also make sure it is ectopic, and then only jump on to methotrexate. And when you give, so always keep in mind, make sure it is ectopic, and then, or else the patient should have symptoms. Then of course you can interfere. And one thing is, when you give methotrexate, the dose is not 1 milligram per kilogram body weight, it is 50 milligram per square meter. It will work up to some 70 or 80 milligram depending upon the body mass. Usually what is given is 1 milligram per kilogram body weight, like you give in tromboblastic disease. It's not like that. It should be a single dose, 50 milligram per square meter, and you repeat the beta HCG 4th day and 7th day. 4th day, if you find a doubling of beta HCG, of course, you are justified in giving a repeat dose. If it is not doubling or slightly increasing, you can ignore it. And if on day 7, it is not decreasing 15-20%, then of course, we can give a second dose. And nowadays, there are papers saying that we can do give a second dose on the 4th day, the beta HCG is doubling. Then the success rate will be high. And initially, if you find the beta HCG is very high, it's nearly 10,000, we can give give a multi-dose regimen with polinic acid. One day methotrexate, the next day polinic acid, the next day methotrexate. Then of course it is 1 milligram per kilogram body weight. It's not 50 milligram per square meter. And another thing is cesarean scar pregnancy and cervical pregnancy. If we give some medical management, the bleeding will be less. And cesarean scar pregnancy, we can, as you have already said, we can easily manage laparoscopically. We are managing routinely laparoscopically. We have managed laparoscopically first case in 2014, and now we have managed some more than 9 cases, and all successfully managed, no complications. So we can manage laparoscopically cesarean scar pregnancy. Only thing is, as you have already described, we have to inject vasopressin. She will not bleed. She will not bleed.
Shall I add one more point? For
Yes.
cesarean scar site ectopic pregnancy, if you pick it up in the very early stage, what
Very
I do
early.
is I give them only methotrexate, 2 doses.
Yes, that is what I
Wait,
said.
that
Early-
become
early-
avascular. Then under histoscopic guidance, we can do a resection, or we can just do a removal of the scar site ectopic. Usually it comes out very well, and I have had nearly 7 or 8 cases of scar site ectopic, among which I have only laparoscopy was done only for 1 patient. So the rest of them I have managed only medically. Similarly, cervical pregnancies also, if it is not very late, beautifully it can be managed by methotrexate, and the bleeding can be very well arrested by Foley's. That also we have done.
all these ectopics, if you diagnose early, can be managed with methotrexate.
Medically, yeah.
And of course, even if you interfere, the bleeding will be less if you have already given methotrexate. And
Yes.
the thing is, whether it should be a hysteroscopic management or laparoscopic management depends upon the ultrasound finding. If the scar pregnancy bulges into the bladder, it should be laparoscopically managed. If it doesn't bulge into the bladder, it can be hysteroscopically easily managed. We are managing
early
hysteroscopically as well. So thank you, Dr. Asha Jain, for inviting me and giving this opportunity to speak to all of you. It was nice, non-tubal ectopic pregnancy.
Thank you, ma'am. Thank you so much for your
Ectopic is,
input and your
ectopic
time.
It was very nice. Okay.
Thank you, Pratik sir. And thank you, Meeno ma'am. We would be really happy to have you if you can just be there in case we need you, but if you cannot spare the time, then that's fine. Thanks a lot. Thanks a lot. Ramani ma'am, MC Patel sir, Meeno ma'am, Pratik sir, we would be really happy to have you, but if not, thanks again. And now we start the panel, and the panel is going to be all about ectopics. Sir has shown the guidelines on which I have actually based this. The expert is Dr. Rinpui. She is not joined. She is traveling. May I have the next slide, please? These are our panelists. Dr. Revati Rane, Secretary, Aklut Society. Suchitra Narayan ma'am, Secretary, Ajmer Society. Dr. Vandam Mawai, Secretary, Aizol. Dr. Namrata Bharadwaj, Secretary, Aligarh. Dr. Amit Karade, Secretary, Ahmednagar. These are the people I see here. Dr. Debashish Das from Agartala, Dr. Ganesh Wagmode from Akluj, and Dr. Mukesh Patel from Ahmedabad had also consented they might join us later. But we start the panel, I think, with the faculty that we have. And you've had speakers who have actually covered everything. So now it's going to be really fast forward. So first we go to the introduction part, and I would request all my panelists and who want to join in the discussion, please put on your videos and let us enjoy this discussion amongst friends. So how would you really define ectopic pregnancy? Dr. Priya, you're also welcome to join in if you wish.
Yes, ma'am. Thank you.
Thank you. So how would you define ectopic? Let's have it rapid fire. We'll end in half an hour.
Okay, ma'am. Will you be telling us whom should tell you,
No,
ma'am?
just take it
Anybody?
up. Anyone who starts, no issues.
Okay, ma'am. Gestational sag implantation outside the uterus. Basic definition of ectopic pregnancy. Any sag which is not implanted inside the uterus.
So now what is the incidence? Dr. Amit, would you like to say something?
Yes, incidence of ectopic pregnancy is about 1 to 2%. It may be underestimated due to in most of the cases it is detected early and it is managed by on office or on OPD basis. So incidence may be quite high, but on reported it is 1 to 2%.
Okay, because there is a lot of difference in the data between the Western papers and the papers that we have here. You know, there the incidence is in thousands, 0.9% is what they say. But here we are seeing much higher, and what Dr. Pratik just said, that you have even scar ectopic 1, heterotopic 1 in 100. So that really makes it very high. So what is the contribution? Yes, ma'am? Somebody wanted to say something? What is the contribution of ectopic pregnancy to maternal mortality?
Hello.
Yes, Dr. Revti, tell me.
Yeah, so the percentage is around 2.7%. Initially, the contribution was quite high, but with better diagnostic modalities and better approach to the clinical health aids, the percentage has now decreased. It's around 2.7%.
May I know your source, from which paper you took this data?
Ma'am, it has been like the sources are like I can forward you the source.
See, actually, what I read through is that you need the contribution of ectopic is still 15% among pregnancy-related deaths. It's not 2.9%. Yes, it's 9 to 14, 15% is the data that we have. Anybody else wants to say something about this? So, Jaya,
Ma'am, I
please
agree
put
with
on
you,
your
ma'am.
video.
Yeah,
Put
ma'am.
on
I
your
agree
video.
with you. Yeah, I agree with you, ma'am. It is 9 to 14%. I think even in Dr. Pratik Tambe's presentation, he mentioned that it's a very common cause of maternal mortality in the first trimester, actually.
So even if the incidence is low, but still it has a very significant contribution. So ectopic pregnancy ruptures are the leading cause of maternal mortality within first trimester, 9 to 14%, and an incidence of 5 to 10% of all pregnancy-related deaths. These are all from the paper that Sir has shown. So now this is a case, and we are going to discuss it threadbare, right, left, up, down. There's a 25-year-old Gravida 1 para 0 with 6 weeks of amenorrhea, and she has come to the OPD for checkup. There is no comorbidity. Her UPT is positive. A routine patient has just come into your OPD. What are you going to do?
Perform a JVS, ma'am. If we can demonstrate the presence of a proper intrauterine sac with an absence of any adnexal mass, I think that should suffice in the first visit.
So I've written, would you do a beta HCG, or you would directly opt for an ultrasound, whether you would do a transabdominal or a transvaginal? Dr. Mamawai?
A transvaginal I would prefer, ma'am.
Routinely, like in our setup, like in Mizoram, we most of our patients cannot afford a beta HCG as such. So, but since in the government setup, we can do a transvaginal sonography, we can do it immediately. Or maybe like sometimes we call them after 2 weeks when the fetal heart can be like nicely appreciated if there was no risk factor. Of course, the history of the patient is very, very important here. So depending on our degree of suspicion, we'll go accordingly.
Ma'am, I would like to add on.
Yes.
Ma'am, if we can do transvaginal ultrasound, it will also help us to know whether there is a tenderness And also, if the transvaginal ultrasound is not available, we can do a simple PV. And if there is a cervical tenderness, then we have a high suspicion for an ectopic pregnancy.
Okay, Dr. Amit, would you like to add something?
Yes, ma'am. As her UPT is positive, we'll do transvaginal. Only if we cannot found any intrauterine pregnancy, or then we can go for beta SCG. Otherwise, transvaginal is more than sufficient for these patients.
Okay, so in your transvaginal, do you routinely look at the adnexa or not?
Yes, we routinely.
Yes, ma'am. We do.
Dr. Suchitra?
Yes, ma'am. Routinely we have to.
So you are all doing your sonographies yourself?
Yes, ma'am.
Yes.
That is good. That's a big change that Foxy has brought. So we are done with this. Now, this patient is a routine case, but supposing she was a high risk case. So what denotes high risk? Which patient would you call high risk?
Ma'am, any patient who has a damaged fallopian tube baseline, because that is the basis of a tubal ectopic pregnancy. So any patient of pelvic tuberculosis or endometriosis, or maybe a prior surgery on the tubes, even a history of ectopic pregnancy earlier on is also said to be a high risk factor for these cases, and ascending infections. Then lifestyle like smoking and elderly ladies of more than 35 years of age, and sometimes anatomical anomalies. If we have anatomical, like a rudimentary horn or something, we can, these are the cases. And of course, IUD pregnancies with IUCDs, and as Dr. Pratik rightly said, pregnancies with ARTs now are risk factors.
Anybody wants to add anything? Anything left behind?
Ma'am, I think
Patients who are undergoing treatment for IVF, like ART pregnancies.
Yes.
And patients who are on progesterone only pills.
Yes.
I think a special mention has to be made about women who get pregnant with intrauterine contraceptive device, ma'am, because the likelihood of a pregnancy in them is very low. But if they get pregnant, likelihood of ectopic is almost 53%. So we should be very sensitive to these patients who conceive with IUCD.
Now, I come to practical questions. How many of you actually ask your patients whether they are using tobacco?
Practically no one.
We don't.
Because to ask the question to females is very difficult.
So
And very
that is why, that is the
also.
purpose that how we are going to change our practice after we are in this panel. We all know the theory. So we are basically going to discuss, the gaps where in the delivery, like Dr. Mamavai said, that we might call the patient 2 weeks later. And then you would be actually missing the chance of diagnosing a pregnancy outside the uterus. She's at 6 weeks, you call her at 8 weeks. So one chance is gone. She might end up with bleeding in the future. Then none of us are actually asking whether the patient is using tobacco. If her husband is a chain smoker and she's living with him all the time, it's, worse than actually smoking herself. So these are the things that we need to actually ask starting today. So now half the patients with ectopic have no known risk factors. Just like breast cancer, only 5% with the BRCA mutation will actually get cancer, So risk factors include prior, this has been dealt with. So this is done.
I want to add one more thing in
Yes,
high-risk
sir.
patients.
Please proceed.
In especially those patients who are undergone IVF, we always find, if we find one sac, we always find for second sac. If one sac is found intrauterine, always search second on fallopian tube or an adnexa. These are the most high-risk patients for ectopic pregnancies.
Heterotopic pregnancies.
Okay. So that is what sir said, 1 in 100. So all of you are running so many cycles. So in that case, the incidence would be really high. So sir showed this, that what are the types of ectopic pregnancy and what is their incidence. So, in this chart, what I would actually, anybody wants to say something about it?
The tubal is the most common ectopic
Still.
pregnancy. You have to be sensitive to that.
So now we come to the problem that what is the differential diagnosis? If a woman with 6 weeks, 7 weeks pregnancy comes to you and there is pain in her abdomen, could it be something else? Or it just has to be ectopic?
No, it could be acute appendicitis. There are a lot of differential diagnosis for.
So now let us just bring those up because students are also listening. So let us bring up the DDs.
Obviously, it could be a early pregnancy loss, kind of threatened or inevitable abortion kind of pain. It could be ovarian torsion could be there. And as the ma'am said, there could be acute appendicitis, other medical conditions that are associated with the pregnancy, like any calculi, renal calculi could be there.
You could have
We can have different differential diagnoses according to the site of the ectopic, So the tubal ectopic will probably can mimic a hemorrhagic cyst or a torsion.
No, we will go to the mimics later. We are taking that she has come with pain, abdomen, tenderness.
Okay.
So then what is the
don't know what
DD
the
here?
location is, so we can't.
Okay.
Ma'am,
So you-
ruptured corpus luteal cyst also may be there.
Yes, and PID is there.
Yeah.
Acute PID. There could be a urinary calculus.
Yeah.
Again, that would be on one side. So, anything? So, what are the diagnostic methods? Pratiks are dealt with, so let us take this fast. What are the diagnostic methods for diagnosis of ectopic?
Transvaginal ultrasound is the gold standard along with beta HCG. So those are the two things that we should be sufficient to help us to diagnose and to decide the management of the patient.
Okay. So could you, sir has dealt with it, but again, I would like you to speak a bit more on serial beta HCGs.
Ma'am, if the beta HCG levels are less than 1500, we repeat it in 48 hours, in which case in a viable pregnancy, they should be rising at the rate of 49% within 48 hours. Sir also told us that if the levels are initially higher to begin with, the rise is a little less in the tune of 30 to 40%. And in case of decreasing beta HCG levels in 48 hours, it could either be an early pregnancy loss or maybe an ectopic pregnancy.
Okay. So how many of you have seen a failed ectopic pregnancy?
Yes, ma'am.
Yes.
Okay.
I have. I have.
So I will ask you what are the ultrasound findings for that later. We'll come to that. So this is it. Now there's an early pregnancy. It could be normal, it could be ectopic, or it could be unknown location. And how are we going to diagnose? It is only by ultrasound and beta HCG. Okay, and this is all the things that can be there. Location of the ectopic, and then there's another thing. What is a morphology of ectopic? What does morphology mean? When you do an ultrasound, you see something. So what is a morphology of the ectopic?
It means the tissue which is evident, whether it is anechoic, hypoechoic. So it gives you a picture, an idea as to what it could likely be, whether it could be blood, tissue, bone.
Because an ovarian ectopic and a corpus luteum, they look very like each other. How are you going to actually differentiate them?
We have to
You
put
have
the
a corpus
color
luteum.
Doppler.
Yeah, Doppler
You
study.
put the color, then there is a ring of fire in an ectopic. There is also a ring of fire in a...
We have to see for the RI index.
Okay, what would you like to see in that? So we'll take that. We will take that. Yes, Sujaya, want to say something?
Ma'am, you can look at the echogenicity and come to a proper diagnosis.
See, ideally, you should be able to see a yolk sac in case it is a gestational sac. Then you should be able to see the trophoblastic tissue, which is different from a simple ovarian tissue. The border of a corpus luteum and the border of a gestational sac.
There's a
You are
variation.
extrapolating from the uterus outside. So this is it. So you would measure the gestational sac in 2 diameters. Then if there is a hematosalpinx, again you would measure it in 2 dimensions. So always what you are measuring is a 3D. First, in whichever section you are looking at, you are taking 2 views. Then you are rotating your probe 90 degrees and taking the another measurement. So that is how you get the correct measurement of that tissue. Hematosalpinx to be measured inside to inside. Solid tissue edge to edge. So this is it. This is the residual ectopic. This is the ovary. What do you see in this? The blood supply has decreased. This is a corpus luteum, this one. The blood supply has gone down. It looks solid. You don't see anything else. It looks mostly like a solid corpus luteum. But a corpus luteum is never solid. Yes or no? Come on.
Yes,
We
yes.
are all experts here.
Yes, yes.
This is the corpus luteum. At the most, it will be hemorrhagic, right? So you will see blood inside, or it will have shadows inside, but it will never be solid like this, will it?
No.
No.
Have you ever seen a solid corpus luteum on ultrasound?
No, it usually has anaerobic endings.
That's it. So what are the experimental markers for diagnosis of ectopic pregnancy? Sir actually spoke about
had a
this.
slide on that. Yes, ma'am.
That's it. But these are all experimental. We have used progesterone in our practice at times. Okay, the negative predictive value is 58%. And if you see even beta HCG, the negative predictive value is 76%. Means without beta HCG also, there could be a positive pregnancy. Right?
Yes.
This is what this chart is telling us. And would you do a DNC? Our seniors were speaking about doing a DNC, you know. So why would you do a DNC and get tissue?
See the
Ma'am,
area
but
Actually, if we found
find the chorionic villi to rule out
No, but if it
Ma'am,
is
in
ectopic,
today's
then
scenario, no, ma'am, in today's scenario, and it could be a viable pregnancy also. So you have to ensure that, you know, it's either a non-viable pregnancy or the lady doesn't desire to continue intrauterine pregnancy. Only in that instant will you offer them endometrial sampling. Otherwise, you would be harming a very healthy, viable pregnancy. So I think
now
in the
this is it.
Medical legally, ma'am, it might hold significance. That's why we have to, state whether it was not a heterotropic pregnancy. So we can, to avoid the injury, we can do just suction and send the sample and to avoid vigorous curettage of the cavity.
Okay, so we
That is
come
after you
to
confirm
saving
or
ourselves
ectopic.
medico-legally.
Yeah, yeah. So medical legally, it might be important considering the current scenario.
So, I'm going to ask you medico-legal questions also as MC Patel sir is here. So, these are the different types of pregnancies, ectopic pregnancies. What are the clinical mimics? Supposing it is a tubal pregnancy, then what is a mimic?
It could be a hemorrhagic cyst. It could be tubal acute appendicitis.
Okay. Interstitial pregnancy?
Yes, fundal fibroid
Angular pregnancy also.
necrosis, or it could be an angular pregnancy, ma'am.
What about cesarean scar pregnancy?
It could be a pregnancy which is intrauterine but low lying. It could be a pregnancy which is failing.
A hematoma?
Hematoma or abscess, yes, ma'am. It could also be a
fibroid,
pedunculated fibroid also. Yeah, pedunculated fibroid.
Now, if we have a heterotopic pregnancy, what could be the mimics? You're doing an ultrasound, see the patient doesn't come with a diagnosis. You have to diagnose. So how are you going to see that the heterotopic pregnancy diagnosis is correct?
Usually you could confuse it with a corpus luteal cyst. So you have to be, as you said, you use your ultrasound markers to differentiate corpus luteal cyst from a
heterotopic means one pregnancy in the uterus.
And one in the adnexal.
Now, one is outside. So how are you going to look for that second pregnancy?
If it's an intrauterine
You
pregnancy,
as clinicians, how are you going to look for it?
you look for the double decidual sign, ma'am. You have to confirm an intrauterine pregnancy. So you have to look for the double
It's
decidual
there.
sign.
The intrauterine is there. How are you going to look for the extrauterine pregnancy?
So you look at the tube, the ovary, and see if you find the ectopic there. Explore, see if another pregnancy located elsewhere beyond the uterus.
And if the patient also has fibroids, you might not really be able to see beyond. And then coming back to what Dr. Revati said, we have to make ourselves medico-legally safe and write that we could not examine this portion because of it was obscured by fibroids. Instead of writing it's all normal.
Okay.
Okay.
Yes, ma'am.
Okay. So ovarian pregnancy to be confused with what?
Corpus
Corpus luteum is pretty common.
And abdominal pregnancy?
Abdominal
Usually
pregnancy.
you don't find it's very difficult to identify an abdominal pregnancy, honestly, confusing it.
Maybe a splenic rupture, ma'am, because there'll be so much hemiperitoneum in an abdominal rupture pregnancy.
Very difficult to
So
diagnose.
there is a 7 times increased risk of organ perforation and catastrophic hemorrhage, and maternal mortality is more than 10%. So there you are not really worried about the diagnosis. You have opened if the patient is in shock, you're going to open her anyways. This sir has dealt with, right?
Yes, ma'am.
Whom we are going to give surgical treatment and whom we are going to give medical treatment. Are there any hematological tests to diagnose ectopic pregnancy? Sir touched upon this. Anyone read anything?
Same
He
table
said-
says, ma'am, CBC, we do a CBC, there may be increased monocyte count. Then there
Yes.
be platelet distribution, width, CPKs, placental volumes, neutrophil lymphocyte ratios. But none of
But
them
the
seem-
most important
not
thing that I noted as well was that you will see an increase in monocytes, which we don't see in any other condition.
Yeah.
So I think that is something should be our takeaway. And what are the indications for medical management? Sir has dealt with it, so if somebody would just quickly go through it.
Patient should be stable, vitally stable. There are no signs of rupture. Beta HCG should be preferably less than 5,000, and the sac diameter should be less than 4 centimeter. And mostly, there should not be any contraindications to the use of methotrexate. So those are the indications where we can give medical management.
Patient should be
not be
looking
a
for follow-up
heterotopic
and she
pregnancy.
should.
Yeah, that is also important. Yeah. So patient compliance is very important.
Follow-up and
There
consent.
should be no heterotopic pregnancy.
Yeah.
Would you give it to a breastfeeding mother?
No,
No,
ma'am.
it is contraindicated. Yeah.
Contract.
So how long do you want the woman to not conceive?
3 months.
Minimum 3 months.
3 months is the recommended time.
You avoid the teratogenic effect of the methotrexate.
Yeah, methotrexate.
So actually, how many of you have actually given methotrexate to your patients?
Yes,
Given.
We have.
Sometimes.
Means one thing off the track I'm asking you, have you noticed a change in the complexion of the lady?
There is a change. They also develop angular stomatitis. We've seen that also.
No, I have seen one of my patients turning dark. She was fair and she just turned dark after she took methotrexate.
She went out in the sun.
Maybe that might be the.
Why is that, ma'am? Any basic?
I have no idea, but she actually turned black.
My God.
Ma'am, actually supposed to be, you can have dermatitis if you're on
Yeah.
to go, it's photosensitive.
It should be avoided.
So that is one. And now, what sir said that you should never ever give folic acid. So when you say she doesn't conceive for 3 months, you are actually asking her not to conceive for 6 months, right?
True.
3 months you are stopping her folic acid, then before pregnancy, another 3 months you're giving her folic acid, then you want her to conceive. So the minimum interval would be
6 months.
Now this is, what is an expectant management? And when would you do expectant management?
Expectant would be, yeah, please,
Ma'am,
someone
when the beta HCG levels are less than 1500, ma'am, the patient is of course hemodynamically stable. There's no evidence of rupture. The sac size is less than 3 centimeters, and she doesn't have any clinical symptoms. Also, no pain, just amenorrhea. And of course, she should be willing to be. She should be well compliant with whatever we ask her to do. She should not be geographically isolated. I mean, she should have access to healthcare anytime, and should be intelligent enough to understand actually when she requires. Because these are some patients who seem to have a resolved ectopic. Ma'am, maybe you can tell us more about it. But
there, Dr. Suchitra, would you read this out?
Yes, ma'am. There should be no any pain and tenderness attributed due to the pregnancy, and low and falling levels of the beta HCG should be there, and the initial level should be less than 1000. Ultrasound findings should be in conclusion. I mean, there should be no any sac or that should be certainly visible on the ultrasound. So consider if there is a falling beta HCG levels are there within 48 hours and patient is absolutely fine without any complaint, then she should be a best candidate for the expectant management. And
now, what are the indications for surgical management?
The patient is not hemodynamically stable. She has features of rupture, syncope, shoulder tip pain. On ultrasound diagnosis, you've confirmed a rupture. Or if you have fluid in the POD, hemoperitoneum is confirmed. These are indications. Besides that, even if the initial beta HCG value is more than 10,000, you have to consider surgical management. She has contraindications to methotrexate, which were previously indicated. She's breastfeeding. All these conditions you can consider to directly go in for a surgical management.
Now, I would like to titillate your gray cells a bit. That supposing you're not giving methotrexate and the patient doesn't want to have surgery, then would you think of uterine artery embolization or giving KCL?
I think giving KCL would depend on the location of the pregnancy, ma'am. Can it be considered for everyone? I don't think so.
Okay.
Now,
what about embolization?
Embolization has its impact on the future fertility. So I guess because your uterine artery embolization will impact your future fertility to a certain extent, ma'am.
Okay.
Ma'am,
So you have decided you're going in for surgery. So when would you do a salpingectomy and when will you do a salpingotomy for, and for which type of case? Where would you remove the entire tube and where would you repair it?
In case when the tube is ruptured, when the tube is severely damaged, the patient is bleeding, she has had ectopic at the same side of the tube before, and she doesn't want to, conserve her fertility. In such cases, it is better to go ahead with the salpingectomy, and if she wants to conserve the tube, her fertility, and the tube is not damaged, is not bleeding actively, then we can go for salpingostomy.
I think it depends upon the health of her contralateral tube. So importantly, if the contralateral tube is healthy, please go ahead with the salpingectomy. If the contralateral tube is unhealthy, there are subfertility issues, then you have to try to preserve the tube and go in for a salpingostomy.
No, the same tube should also be, we have to look, because we cannot rely on other tube. We do not know how that tube is. We cannot, looking at the external appearance, we cannot judge. So looking at the same tube also, we need to take the decision, I feel.
Yeah.
Dr.
Anyway, ma'am,
Namrata, would you like to add something?
Then we
ma'am,
have
I
to go
feel
for
if
the
the ectopic is not ruptured, even only then we will think of salpingostomy. If the ectopic is already ruptured, there is no question of having a salpingostomy at all.
No, then we have to go.
You have to
But
go for
with salpingostomy, there's always a chance of persistent tropoblastic tissue remaining. So if the patient, you've counseled her in today's scenario, considering all the medical legal, she should be prepared to go in for a subsequent methotrexate therapy, or you might have to open her up for a subsequent salpingectomy. So if she's willing for all that, then only I think you should consider. Otherwise, you should be
So this
cautious
is
when
it.
you offer that.
So you people have really covered everything. Contraindications to medical management have also been dealt with. So when would you refer the patient for surgical treatment? You have kept her on medical treatment and she's hospitalized. When would you actually refer her? Or decide to operate her?
Ma'am, when you're doing the serial monitoring of the beta HCG and you've done your day 7 beta HCG monitoring and you see the fall is not more than 15%. So then you can
Dr.
either...
Suchitra?
Yes, ma'am. If the patient becomes hemodynamically unstable, unstable patient, if she develop a gross hemoperitoneum and there's a shoulder pain, backache, and the peritoneal signs develops, and if on ultrasound the fetal heart means live ectopic shows, then these are the absolute indication for the referral and either to operate laparotomy. But in cases of beta HCG follow-up, we can go for a beyond the day 7 also. If there is no any fall more than 15% after day 7, then again we can go for day 11 beta HCG with the methotrexate doses. But patient should be vitally stable in that cases.
Okay, so in any case of hemodynamic instability is when you're going to go ahead and operate.
Yes.
So which route would you prefer for surgical management?
laparoscopy.
Laparoscopy should be, yeah. Laparoscopy should be.
So when would you not do laparoscopy?
In a very unstable, hemodynamically unstable patient who requires quick surgery.
Patient is in the shock.
And if you don't know a laparoscopy, of course, then you will not do a laparoscopic surgery. You don't know
Agree. But what is the condition of the patient where you would not opt for laparoscopy?
If she's in shock, ma'am, if she's hemodynamically unstable, I don't think we should go for laparoscopy. We should straight away do a
Dr. Revati, want to add something?
Ma'am, it depends upon the laparoscopic expertise also that is available. Like right now we saw the non-tubal ectopic pregnancies are very, it requires a lot of laparoscopic skill. So like the rupture corneal ectopic and everything. So it depends upon the expertise of the laparoscopic surgeon also. So depending upon that, the patient's life is more
Means what I'm
important.
saying is in the best of scenarios, you have all the skill. Still, there are some patients whom you would open. So who are those patients?
Whether hemodynamically unstable, you're having to require inotropic to keep them stable. They're being started on any inotropic and then only you're able to stabilize them. I think such patients have to be opened. Laparoscopy wouldn't be warranted in such cases.
Dr. Priya, would you like to add something?
Ma'am, those patients who are in shock or those who are having cardiac diseases or they are on any anticoagulants.
Okay. So now, how would you follow up? If the woman is on expectant management, how would you follow up?
On expectant management, we have to repeat the beta HCG after 48 hours, like for and monitor her, and then we have to repeat it for like a week, and then we have to repeat it weekly till the time it is negative.
Okay. What about medical management? If the medical management has been given, is it the same?
Day 4 and day 7, we do a beta HCG, ma'am. If the decrease is more than 15%, we tend to think that the medical management is getting successful, and then weekly beta HCGs again till the beta HCG is negative.
What about surgical management? How are you going to follow this patient? You've done her lab. She's okay. You're discharging her on day 3. How would you follow her up?
Ma'am, if she's had a salpingostomy, then we need a beta HCG weekly.
Has to be done weekly again until it's undetectable.
And
So
otherwise,
that is the most important thing that I would like everybody to remember, that you also have to do beta HCG even if you've done an open surgery or a laparoscopic surgery. So
Especially
now
with
the
that.
patient has come to you. We come back to Dr. Revati. Your patient has come to you. How would you counsel her when she's being admitted, after diagnosis, while suggesting treatment, and at the time of discharge? One by one, you can take one part. How would you counsel her for admission?
If the patient has come to me who is already in a lot of pain and shoulder pain and she is already in shock, then the counseling the part of need of admission is not that difficult. But when the
But
patient
for
is
medical, you're giving
for
a medical
medical,
treatment.
yes. For medical, when the patient is stable and actually they have come to you just for PV spotting, and then we tell them that you have an ectopic pregnancy where they are not expecting that, especially when they have undergone tubal ligation and everything. So that times it becomes difficult, but we have to counsel them, show them the picture or diagrams and what can happen. We have to tell them the risk that are involved, and we have to give them the option. And if she is ready to get admitted, ready for the follow-up, for the medical management which is required, because she has to follow up, do beta HCGs, and we have to monitor her clinically, and then we go ahead, we decide the plan for that patient, and we can go ahead with the medical management.
So,
Ma'am, I think when you're counseling, you have to explain the risk involved. Give her a picture that when you're managing her medically, very high likelihood that it might not regress. We'll have to then consider you, or if there's a rupture and then immediately you'll be taken in for surgery. Are you willing for all these complications? And are you willing to take the risk? She should clearly explain.
Dr. Suchitra, what would be the content of your counseling?
Regarding the admission, I have to counsel the patient that
you are suggesting treatment to her. What will you counsel her?
According to the condition of the patient, we need to explain every condition and the situation regarding the need of follow-up, stay inside the hospital, and the need of conversion of the mode of treatment. Like it could be convert from medical to surgical, and we need a multiple investigations, and she should stay with us. So this is the most important.
So one of you, I want you to tell me, how would you counsel? Means is it a video counseling? Is it a documentary counseling? What is going to be recorded or not recorded?
It should
video
be
counseling
and with the documentary counseling. Should be
So you need to counsel everything on paper, and then you need to sign it, and you need the patient to sign it, and you
Yes.
need 2 witnesses to sign it.
2 witnesses.
Yes, because what is happening is that today we see early pregnancy mortality 10 to 15% is because of ectopic. Can you predict nothing is going to happen to your patient? You cannot. So everything has to be written down and everything has to be signed. Okay? Now, how many of you think that ectopic pregnancy causes psychological stress? The patient is told you have a pregnancy in the tube. Does it cause psychological stress?
Yes. Yes.
Any pregnancy complication and loss, it does affect, because most of the times, as we know, these patients are elderly or having any other infertility issues. So having that, I mean, the whole family is disturbed. They might have to, get the tube removed. So what is her future fertility? How it will affect her future course? So looking at the spectrum of the patients who undergo ectopic pregnancy, they are usually the ones who are willing to have a pregnancy sooner or later. So it does affect them psychologically, and we have to counsel them the modes of treatment that they have, that depending upon the condition of the tube or need of IVF later. So that has to be also taken care of. I mean, we have to give them hope of their future fertility.
Dr. Namrata, anything to add?
Ma'am, any kind of psychological, we need to assure her that she may not have a repeat of ectopic pregnancy, that she needs to be under proper guidance and supervision as before her second pregnancy, so that we can rule out an actual active cause of tubal of ectopic pregnancy. And
Now we have dealt with that part. I'm talking about how are you going to look after her mind, because it is the mind that is responsible for the body, right?
Counseling is the only thing that we can do at this time.
Okay. Would you think of sending her to a counselor?
yes, ma'am, if she requires it, we should. If we are not able to deal with her stress, then we should.
Because, writing sedatives is not an answer. We need to actually give all the facts, help her where we can, but we need to realize somewhere that if she needs help, she needs help. And we may not be able to give all of it. So what medical legal points would you pay attention to in this whole process, from entry in OPD to discharge and good or bad outcome? What are the medical legal points that you're going to take care of?
Ma'am, first of all, we need, as we've already discussed, we need a documentary evidence of the options that she has chosen, whether medical or because we need to tell her all the options, surgical and medical. So we need to be very clear with her that you are the one who has consented for this. You are the one who has to follow this through and we are there to support you. The expected bleeding, which may occur in the course of treatment, the contraception, the follow-ups. I mean, these things need to be put down in black and white before we start any kind of treatment for ectopic pregnancy.
Dr. Priya, if you tell your patient that you're likely to die under treatment, will she come to you for treatment?
No, ma'am. I did not think.
So she will go to somebody else.
Yes.
So what we have to do is we need to put everything down, but put it down in a way that she actually continues to take treatment from us, right?
Yes.
So there are FOGSI universal consents. You can download them and try. It's there on the FOGSI website.
Yeah.
So that is one part. But another thing is that you need it written in the patient's own handwriting, or uska relative will write and they will sign. That is required. And the rule of explaining problems is that you should not explain remote complications. That should be broadly worded. There are other things that may happen and we might have to treat as the situation arises. If you're going to micromanage everything, the patient is not going to stay with you. That is for sure. So, supposing you've lost that patient. She came, she had an abdominal pregnancy, she had a liver rupture, you tried your best and you lost the patient. Okay, you even had a gastroenterologist come in and repair that liver and still you lost the patient. Now, what are you going to do to protect yourself?
First of all, ma'am, postmortem examination is very important in all the cases of maternal mortality, to document it. And then, as we have known from coming to the OPD, we need to have everything, ultrasound, beta HCG, her consent for opting for the treatment, surgical consent of the relatives, and preferably, as we know that, video consents and video recording, if we have the cameras, and it does help in such scenarios when we know that there is high chance of maternal mortalities. In such cases, it is better to have recorded consents when we have already explained the chances of mortality in that patient. So in such
one thing I would like to add here is that if you have called on help, if you have called other specialty doctors, that needs to be documented and they need to write and sign.
Yes.
Your writing and signing doesn't work. To protect you, they need to write and sign.
The second opinion does help a lot in such situation. Yeah, teamwork helps.
The case sheet and OT notes also should be complete, ma'am. You should be able to justify what you've done. So all that documentation, especially case sheets and OT notes, should be up to date.
And your notes, recently in Chhattisgarh Medical Council, we had a case where the anesthetist wrote that the patient is very bad and we are losing the patient. And the surgeon wrote that the procedure was performed, the patient was fine, and I left. And actually that patient died on the table. So this should not happen. You need to be consistent, and the anesthetist and the surgeon and the assisting surgeon, they should all speak the same language and they should also put the same notes. So when something happens, that is what we need to look for. So these are the summary slides. What are the clinical presentations that we get in ectopic? We already dealt with this. Then there are the managements. All three: medical expectant, give written information, and general care. That means histopathology of products of conception is also required. You will give anti-D if the patient is RH negative. And if the patient is being referred somewhere, all information has to be properly documented. Now it is discussion time for 5 minutes. Any of us wants to ask anything? Our experts are still with us. So Prasanna ma'am is there, Ramani ma'am is there, MC sir is also there. Anybody wants to ask something?
Ma'am, I wanted
Yes,
to
ma'am, one
ask
question.
regarding multi-dose protocol which was mentioned, and ma'am said that we can add folinic acid in that if we are giving multi-dose
Yes.
protocols. So
That is from the
wouldn't,
next day.
but
That is
oh
from the
yeah,
next
but
day.
next day, yeah, we give it alternate. So so wouldn't it affect the action of methotrexate in to certain extent?
The folic acid and folinic acid are different.
Yeah, but the folinic acid is the active form of folic acid. So eventually it will, in a certain extent, it will decrease
Agreed,
the
but the
effects of
thing is,
methotrexate.
methotrexate is acting on all the rapidly dividing cells. That is how it is affecting the trophoblast. But you also have RBCs, you have WBCs, you have platelets, you have skin, you have gut, endothelium. You have to live, right? Means the patient has to live, and then she has to get rid of her ectopic. So that folinic acid rescue will have to be given.
So whenever we are giving multi-dose and giving folinic acid, it wouldn't interfere with the action of methotrexate.
No, it's
So we
not
should
given the same day.
Yeah.
Shall I add
Alternate
one
would
more
be-
point, Asha? See, only
Yes,
thing is,
ma'am.
most important thing is we should not give folic acid when we are giving methotrexate. That especially for when we are planning for medical management, and we have to have a LFT and RFT done prior to methotrexate and rule out pulmonary problems in that particular patient. Again, do a basic CBC also. If the patient has already got leukopenia, then we have to be very careful. And no exercise, no coital activities, and if possible, if the levels are very high, beyond 10,000 units, right from the start, we can start the patient on a multi-drug regime. If see, we generally say the medical management is there only when the level is between 1,500 to 5,000. Okay, and when there is no fetal heart. But there are situations when we need to have given medical management for beta HCG beyond 5,000 also. Okay, so that is in situations where the other tube is also lost, and if the patient has got an ectopic pregnancy in a single tube, that is the only tube, then we are forced to go for a conservative management, medical management. So in such situations, when the basic beta HCG level is very high, start the patient on that is a multi-drug regime, and day one is methotrexate plus folinic acid, methotrexate, folinic acid, continue for 4 days. That will give very good results. And especially one more thing is, if the ectopic pregnancy is nearer to the fimbrial region, the moment you give methotrexate, there will be expulsion of the tubal, it will go into tubal abortion and it can cause hemoperitoneum. That also we need to observe. So you tell the patient whenever she has a intense pain on the second or third day, they should rush to the hospital soon. So these are all certain very, very important points when we are following the patient with the medical management.
Thank you, ma'am. Thanks a lot for pitching in. So,
Ma'am,
any
one thing
other
I want to ask.
questions?
Yes, ma'am. One questions from my side. I need a little bit more clarification towards this medico-legal implications when we start our treatment from medical management, and if it converts towards surgical and means kind of poor prognosis or bad outcome happens there, then how to deal with this condition? I'm a little bit more.
See, the basic thing is to document everything. One.
Yes.
Number two is to not be afraid. If all your documents are correct, even if the patient is against you, they cannot really harm you. Okay. So do the correct thing. Do what is as per guidelines. You should be able to produce those guidelines. Third thing is document everything. Fourth thing is when you are operating, it is better to have somebody as a backup, who will agree with your findings, so that if the patient is bad, then you have that person to help you out. So ultimately, all of medico-legal is documentation, 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 and acting as per guidelines. Because whenever you are in court, you have to go to court. You have to produce those guidelines, standard guidelines, that this is according to what I have acted. And these are the complications that can happen. That is the only way to protect yourself.
Thank you.
Patel sir, are you there?
Should I?
Yes, sir. If you can add something,
Yes.
because it's a
Right.
medico-legal question.
Yes, it was very nice discussion altogether. But as far as medico-legal part is concerned, usually in ectopic pregnancy, whenever we are facing any litigation, there are common allegations. One, not diagnosed in time, or second, wrongly diagnosed, or not managed properly. And when surgical intervention was not necessary, medical option was available, still you removed that very tube. These are common allegations as far as ectopic pregnancy management is concerned, medico-legal part. But in this situation, there are two to three things we have to keep in mind not to end up into any kind of litigation. First thing, counseling. You all have stress upon that counseling part, but counseling at the time of diagnosis, before treatment, and even after treatment, counseling is equally important. Even we have managed for medical management, or we have managed for surgical management, possibility of recurrence in that very tube is known. So we have to mention that also in our discharge card or in post treatment counseling. And when we have removed tube, for say for example, if it is a rupture ectopic and surgical conservative management is not possible, and we have to go for salpingectomy, then we have to explain that part also, that that very tube is removed. Still there could be ectopic pregnancy in future, and if she has only tube and you are going to remove that very tube, in that very situation you have to counsel patient accordingly, that you have only one tube and this is a ruptured ectopic, or surgical management is the only answer and it is not possible to save tube. Then all this should be counseled well, and it should be well documented. If you have all this documented well, then it could be in your favor if at all you are facing any litigation.
I hope that answers your question, Dr. Suchitra.
Yes, yes. Thank you, sir. Thank you, ma'am.
Welcome.
Thank you.
Suchitra,
Anybody else has any question?
Suchitra,
Yes,
coming,
sir.
Suchitra, I am coming to Ajmer next month, February.
Oh, thank you so much, sir. So blessed.
It is on
Welcome,
16th of February. So you,
Yes, sir.
you
Yes, sir.
select which topic I have to cover at Ajmer. You talk to
Sure,
your
sir.
president, madam, and select.
Yes. Yes, yes, sir. Definitely we will.
Yes.
Sir, MC Patel, sir, you are welcome to our Trichy program,
Yes,
sir.
I am reaching Trichy also in
Yes, sir.
next month, February.
MC sir, please थोड़ा सा कैमरा ऐसा करिए कि आप दिखें. I want to actually take a photo.
No, his camera is not.
It shows that my camera is working, but it is not getting displayed for any reason. It happens many times. The camera, since it is on, but my face is not seen. But I hopeful I am well audible, so it will do.
Yes, sir. Yes, sir.
Yes.
Ma'am,
Yes,
can I ask one question?
Go ahead.
Asha? Yeah.
Ramani ma'am is also there.
Yeah. Actually, taking the advantage of that, we have so many experts. This is regarding two types of scar ectopics that have been mentioned. That the type 1 which is growing, inside, and the second type which is going outside. So, like a patient comes to us, and usually a radiologist may or may not. They just give the report of scar ectopic. So, how do we, practically? How is it important, or how should we distinguish, and actually does it really affect our line of management? Type 1, type 2, which is growing inside, can grow into a normal pregnancy, or later on grow into placenta accretas, and type 2 would end up into rupture. So I would really like to know about the inputs regarding that.
I think it is a very good question, because the moment we see the scar site ectopic, repeat the scan after few days, because sometimes it might be a normal pregnancy. Falsely, it can be scar site. It can be reported as scar site. But if it is found to be a true scar site ectopic, whether it is going towards the uterus or whether it is going through growing towards the bladder, it doesn't make any difference. It has to be terminated, because going outside into the bladder, it will definitely cause rapid, severe hemorrhage. Okay. Then if it is going inside the uterus also, what happens is the patient might have placenta accreta spectrum. Then again, the fetus may not grow to the expected, to the to the stage of live thing. So I think
Viability.
and the complication is going to be more if you are going to permit the growth of the baby into the uterus. So always when you find it at an earlier stage, it is safe that you have to go in for termination. The ideal way is yearly pickup. Maybe you can go for give methotrexate, wait, or you can, if it is got a live fetus, we can even methotrexate intralesionally, it can be given. And very rarely, if you diagnose it at a later stage, maybe you need to have a laparoscopic excision of the scar site. I tell you one thing, if you can find it out very early, even a vaginal access can be done. Because if you reflect the anterior vaginal wall, you see the lower uterine segment, you remove it, then you can suture that. So that gives the minimal invasive procedure for early scar site ectopic also.
Ma'am, can you comment about isthmosele, which is identified interpregnancy? In the between pregnancies, how would you proceed if you identify it on a scan?
Yeah, if it is an isthmosele, otherwise called as niche, if it is asymptomatic, don't do anything. Okay, the basic thing is you need to have prevention of niche by doing a proper 2-layer closure of the uterus and closing the peritoneum, visceral and the parietal peritoneum. And in any patient with repeated 2 or 3 C-section, then automatically the incidence of niche or the isthmosele increases. So when it causes problem, for example, the main symptoms are, it can cause secondary infertility. Okay, that is one reason. So if the patient comes with secondary infertility, then you have to manage it. Then the next thing is the patient can come not because of fertility, but she can come with abnormal uterine bleeding. Spotting can be there. So that is also significant. We need to manage it. So the management of again niche depends upon the symptoms. Okay. Then you can put the patient, if it is a small degree of isthmosele alone, maybe we can try with the oral contraceptive pill or an LNG IUS. That is sufficient. But if the niche is very much larger, say the residual myometrial thickness is only 2 to 3 millimeter, then these are the cases when if the patient wants secondary fertility treatment, you have to go ahead with, definitely, you have to go ahead with correction of surgical isthmus heel. Otherwise, there is no need. Don't touch it.
Okay.
But nowadays, we are getting lot of IVF patients. They are coming with secondary infertility, and we previous C-section, when we look into them, then we are getting lot of this niche. So that has to be managed.
Thank you, ma'am. Thank you so much.
Ma'am, dose
you,
of
ma'am.
mifepristone dose for management of ectopic.
Yeah, I have not used, I don't have any personal experience with the mifepristone. I cannot say. So
Okay.
probably the same dose as that of 200 milligram of mifepristone in first trimester abortion, followed by either misoprost or thing. But I have not used it personally.
Okay, ma'am.
Ma'am,
But
regarding letrozole, ma'am,
yes,
regarding letrozole, do we give it alone or we combining with there are few papers which are suggesting combined use of letrozole and methotrexate. So
see, the thing is, if you are going to combine, the regression of the beta HCG is going to be faster. Okay, so letrozole itself, it depends. Early lesions, either one. Letrozole 2.5 milligram TDS for 5 to 7 days, that gives excellent results also.
Okay.
Especially that is indicated when the patient has got renal or liver abnormalities. Then methotrexate is contraindicated.
Okay.
Thank
Any
you.
other questions from anyone?
I think most of our
I
queries
hope
have
it's
been
been a good
discussed.
experience. I hope it's been a good experience.
Yes, very
So,
nice discussion.
thank you, Ramani ma'am. Thank you for being there till the end. Thank you, MC Patel
Thank you,
sir.
ma'am.
Thanks a lot for sitting till the end and pitching in when needed. And Dr. Meenu is there, but I don't think she's listening. Thank you, Dr. Meenu. And thank you, Dr. Priya. You were not a panelist, but you pitched in. Thanks a lot.
Thank you, ma'am, for
Prasanna
giving
ma'am, you are still there. Would you like to say something? So thank you, Dr. Prasanna ma'am, Dr. Suchitra, Dr. Revati, and dear Sujya. Thank you, everyone. Thank you, Corona Remedies, for having this academic event. Thank you for being my academic partners. I thank all the viewers as well for being here and making this program worthwhile. I hope it was as useful to you as it was for us. Thank you.
Thank you, ma'am.
Good night, ma'am.
Good night.
Good
ma'am.
night.
Bye.
Forgot to make my vote appear.
You can still make it.
Everybody's logged out. Come on. Mehul, you can end it.